Okay, good afternoon, everybody. I'd like to welcome everyone to this EuroELSO webinar titled Rehabilitation on ECMO, a Team Approach from both an adult and a pediatric perspective. I'm one of your co-chairs. My name's Emma Shkurka. I am a physiotherapist at Great Ormond Street Children's Hospital, and I'll just allow my co-chair to introduce herself.
Hi, good afternoon. My name is Annemieke Oude Lansink. I'm an adult intensivist in Groningen, the Netherlands, and one of my first times as a moderator here on the EuroELSO webinars, so I'm really proud to be here.
So we've got an action-packed sort of hour to 90 minutes for everyone, hopefully with presentations really from everyone that is involved in rehabilitation on ECMO. I'd like to start by just saying a big thank you to all of our speakers. And the other thing just to mention is that this webinar will be recorded and then available on the EuroELSO website for people to watch back as and when they want to. So the format of today is we're going to have several short presentations. We're going to start with lovely Sandra, who is our patient. And then we're going to move on to a variety of allied health professionals and nursing presentations. What we'll do is we have the Q&A function on Zoom. So if people have any questions, if they can put them in the Q&A as we go through. If there are any questions for Sandra, we'll ask those immediately after her presentation. But then what we'll do after each of the allied health and nursing presentations is we'll save the questions to the end, because then we can perhaps have a little bit more of a panel discussion and get sort of different responses and different people's opinions on the same question. We are meant to have, I think, 7 speakers. We are still waiting for a couple to join, so there may be a slight change to the order of the programme. And it also may finish a little bit early. But also that should give us more time for questions. So without further ado, I'd really have pleasure in introducing our first speaker, who is Sandra Peng. She was a patient at the Royal Papworth Hospital, and she's in the unique position to be able to remember some of her time on ECMO. And she's generously agreed to share the patient's point of view of rehabilitation on ECMO. So a really amazing opportunity for us to learn from the patient and also to start off this webinar. So Sandra, if you want to unmute yourself and share your screen.
Thank you, Emma. And you are quite right. I can only remember some of the things during my ECMO journey. But thank you, Emma, and good afternoon, everyone. So my name is Sandra, and I'm just here to share about my ECMO journey, which happened just 2 years ago. 2 years ago. So I'm just gonna share my screen. So what I'm sharing, so I'm Sandra again. I have lived here in the UK for 21 years. So hold on, sorry. So I hope that.
Yeah, and just go to the slideshow mode. Yeah, perfect.
So you can see my screen, my slide, my presentation.
Yeah, perfect, right. Sandra.
Okay, thank you. So 2 years ago, I had condition. So this is I've lived here in the UK 21 years. I have a loving husband, my 3 children, living a normal, normal life, busy, very busy life. I was working as a care assistant on a night shift, and I'm a wife, I'm a mother, I'm the driver, I'm the cook, I'm the cleaner, I'm everything. Maybe some of you women and men can relate to my condition, to what's happening, how our day-to-day lives, a normal day-to-day life. So I have no existing or pre-existing medical condition. I'm just happy and healthy. Even my colleague says, "Oh, you're the healthiest person here in the office because, they're already having high blood pressure and diabetes and asthma and things like that. So I'm just, just normal, healthy individual. Then in 2023, I was diagnosed with dermatomyositis. I have my family, I don't have any family history with that. My, it just so quick, it progressed so quickly. It was so aggressive. It progressed so quickly, but ironically, that the diagnosis seems very long to be able to diagnose me, that by the time I was admitted to the hospital, my lung was already damaged. My lung was already compromised. But, by God's grace, at that time, I'm still like not aware of what's, happening. I just know that I'm not right. I'm not right. So it's just, it started with mouth ulcers around late December of 2022. And then by January, I have already swollen hands, painful hands, not the joints, but just everything. If you can see my pictures, my photos, my skin, like my muscles are all swollen. And I've got this rash and dry scabs that I didn't even hurt my hands. They just appeared, the scabs. And then in my face, I've got rash here on my eyelids. As I've said, I have mouth ulcers, and normally I don't have mouth ulcers normally. So I just really quite ignored it. So I even went to the dentist. I did everything, but the progression of the disease is just so quick. So I was admitted by February or March, early March. I was already admitted. But I stayed a few days in the ward, just a few days, and then they said, "Oh, we need to take you to the ICU." And okay, I said, "Okay." I'm really still not aware how extent my condition, how bad was my condition. So when they sent me to the ICU in the morning, in the evening, they already told me, "Oh, I think we need to put you to sleep. We need to put you to sleep." So they put me to sleep. And the ICU doctor already spoke to my family that, there's a 50-50 chance of your mom surviving. So he talked to my kids, even my kids, as young as they were. They spoken to them, to my husband. We don't have any other extended family here. So, and I don't know how many more days has passed by. I'm not aware, but I think the doctor already again spoke to my husband and said that I am not responding. So the ventilator has already have the highest setting, but it's not working. All the medications they've given me, the treatments, I think it's not working. So it's like it's like, it seems like they're giving up on me. But yeah, so I'm just so grateful. And, I'm so grateful and really thankful. Even up to now, every day I give thanks to the Lord Jesus Christ that, because of He is so good and He's so sovereign, that He put this team of doctors, nurses, specialists, the one who would decide to be able to put me in the ECMO list. You know how big of a deal it is? If, because in the UK, there are only 5. I believe, if I'm right, there are only 5 hospitals in the whole of UK. You know how big the UK is. But we have only 5 hospitals that give ECMO treatments to adults in the UK. And the Lord has precisely put me in a place 20 years ago, near Royal Papworth Hospital. So everything is just designed. No, this bad thing happened to me. but there is already a way. There's already a way. So I'm so grateful to the team, to whoever, the panelists, to approve that I will go through ECMO. So it happened. I don't know how many more days I was asleep, but as soon as I woke up, I really appreciate the team, all the team working together, the nursing team, the ECMO team, um, all the team, the therapy team, everyone, the medical team, to bring me back up, to push me to get out of ECMO and to rehabilitate me. So here, this is the team of the physiotherapists. They come every day to encourage me, to push me up to, of course, pushing me and also giving me space. If they know that I'm tired, I'm asleep, they will leave me, they give me time to rest, to recover. It's a roller coaster journey. The whole journey is roller coaster. One day I will feel happy, or my strength is like, okay, I can do this, and then the next day, oh, I feel really low. The team, the palliative team, they were there to support me, give me guidance, even just talk, not physical rehab, but the talk, it also helped me. They referred me to the psychiatrist because there was one point that I was really crying. I just crying every day. My ICU nurses just, so probably reporting in their daily notes, oh, she's crying from 8 to 7 o'clock. So yeah, I was just sad. So they referred me to the psychiatrist, but I was okay. I was just so sad. So the rehab started. So this is my chart, my diary, rehab diary on the sides. Didn't appreciate this at that time, but looking back now, yeah, it really shows you or me or of the patient the progress that you make, because at that point of time you don't have a sense of time. You just think about your illness, of what you cannot do, from be able to walk and dance and run to just being on the bed. And at that time I really felt that why am I still here? I don't want to be dependent to anyone, dependent on the machine. But yeah, so this helps me to put things in perspective. Like I just started to to be hoisted, to just sit out on the chair for a couple of hours, and then I progressed to just standing. So here, they're standing me with two assistants, because I don't have that balance yet during this time. So from standing, then putting me onto the chair, transferring me. They use all the equipments that are needed, the assistive equipments that are needed. So Sarah Steady, the commode, and all these things, all this medical terminology, the steps. If you can see the last entry on June 16, I already took 176 steps with a smiley face. So yeah, so the rehab team, they were very, very patient with me. So this slide, they are working together. So these are the physio while I was doing my pedaling. There's the OT here, giving me songs, singing for me, which enlightened my spirit. It was really created a wonderful environment, not only for me, but for the nursing team as well. So yeah, all these teams, all this input, it really helped me. Right. Hold on. Next slide. So in this slide, you can see I'm starting to walk, even breathless. So this is one of the lead therapists. Even with all the tubes, they don't need to wait for me to be out of it, even with all the tubes, they are helping me to learn how to walk again. So starting from a few steps here inside my room, we have progressed now to walking outside the corridor. So this is outside my room. So this is the walkway, the hallway. And you know how big of a task this is. It's very, I want to emphasize this because with our staffing conditions, probably around the world, so you can relate, our staffing conditions in the healthcare industry is it's quite alarming. And, everyone is burnout or tired, but for a patient to be able to do this exercise, it takes, I think, four to five staff to be able to just do this. And so I'm really grateful for that input, for the time, the help. So they also gave me spa time, relaxing, foot massage and foot soap, to give me that self-esteem and just to relax. Because person going through this, you might, it's really difficult. It's really difficult. You might not imagine it, but there's the highs and lows. And and I am a positive person. I am a positive person. I'm a very faithful person. I'm a believer. So what more for those people who is quite lonely or who don't have a family to support them? So the medical team really helps a lot for a patient to improve. So I also have this sunshine therapy in Royal Papworth. So, this in Royal Papworth, they have this ceiling to floor windows. So it's really, really nice already. Really nice in the room. Have floor to see the whole big windows so you can see the sky. But it's still, being there I was in the ICU for 4 months, 4 straight months. And being there for 4 months in the ICU, one-to-one with the nurses, with a close, I'm in isolation room. So just being one-to-one with the nurse, with limited visiting hours. So you feel really entrapped. So this session, sunshine therapy, they called it, I was able to come out, have the fresh air, feel that sun in my skin, feel that wind in my skin, in my lungs. So this is really a good positive input from the team. And another thing, it takes 5 people, a perfusionist, I think a medical doctor, and of course my ICU nurse and another nurse to transport me from my room to here, to outside. And, because it's a hospital setting, I wouldn't be able, and to meet my family, my family, my friends, this is really a special time for me. I have my nephew, the little boy on top. He wouldn't be able to come and see me because of the restrictions in the hospital. So they came over all the way from the Philippines to see me. And yes, they were able to visit me all at the same time and see me even for just a short period of time. So finally, after, I think it was July, I was be able to came off. I came off ECMO. Again with the help of the nurse, with the help of the lead ECMO nurse, who unfortunately is not here with us today, Fowles. She had an open, honest talk with me that she said she thinks she put her faith in me as well. She said that I can do it. It's so scary, physically and mentally to come off ECMO after a long time. So it's just the physically draining, when we were practicing, weaning me off, that you feel breathless, you feel hot, you can't understand what you're feeling. So it's quite difficult to come off of it. But yeah, so Joe had an honest talk with me that she said, no, you can do it. And I did. I was able to do it in 48 hours. They took it off after 48 hours. So I really thank God. I really thankful for the team again. But of course, everyone is different. So everyone have a different, your different personalities, your different inputs really have a contribution towards in caring and the treatment of a patient. So I just want to thank you. So this picture is, I was already still in the ward recovering. So we celebrated our 19th wedding anniversary there. So these are my children, my 3 children. The earlier picture was an old picture. So here they're a bit grown up now. But yeah, all the team from uh, from the medical team, the physiotherapists, everyone contributed. So the researchers, to developing this kind of treatment, more advanced treatment for people with different kind of illnesses. So I'm really thankful for all your contributions. So this is so I came back for a talk to Royal Patford. So I was already discharged, maybe, and then a few weeks after. So was able to also share my experiences. These were my nurses, my ICU nurses. I think they have been promoted at this time, so they were attending a conference as well and learning about this ECMO and rehab. So I want to thank you for listening to my story, and I just want to close this with a verse in Psalms 118:17. I will not die, but live, and will proclaim what the Lord has done. So just thank you so much. And I hope you all have a nice day.
Thank you, Sandra. That was an incredible presentation. And I think really highlights what a team game it is, and also at some points how high resource it can be. Annemieke, I don't know, are there any questions, or have you got any questions?
I was monitoring the chat, but I did not see any questions. I have lots of things going through my mind, and I think everyone who's joining here has the same, listening to your story. And one of the things I wanted to ask, because there are millions of things I want to ask you, but thinking that most of us are working in the hospital, what is one of the things you would want to tell us from your experiences? What is one of the things that gave you lots of positive energy, and which what we can do for future patients? Or if you have something that you say, hey, you never should do that again with your patients being awake on ECMO. Is there something positive which we can take back to work tomorrow if we have a patient who's awake on ECMO and in a critical phase like you were yourself?
Um, I think it's just, being patient, really being patient, and going back to the foundation of why you do what you do, to fall in love again of what you do. Because yeah, especially for those who have been working in the healthcare for maybe 20, 30 odd years. So treat every day a blessing, a different patient. I know sometimes it's hard, it's really tiring and burnout, but treat us differently every day with hope And yeah, going back to that passion that you love to care, you love to deliver, you love to help people, you love to treat them, and yes, go back to have a normal life.
And seeing someone like you helps us do that. There are popping up some questions, and I think most of them will be met in the talks by the other professionals following you. So I think, Emma, maybe it's time to thank Sandra and progress to the other parts of the webinar.
Yeah, amazing. Thank you, Sandra. So now we're going to move on to the talks by our varied professionals panel. Each participant has around 10 minutes. And then if you, as I said earlier, pop questions in the chat and we'll ask as many as we have time for at the end of the presentation. So my first the pleasure to introduce the first professional speaker, so Tanya de Silva, who is a pediatric speech and language therapist at Great Ormond Street Children's Hospital. She specialises in acute paediatrics and neonatal feeding and communication development skills. And she's based across sort of the cardiology ward and the cardiac ICU. So Tanya, I don't know if you want to share your screen and unmute yourself.
Thank you, Emma. Thank you for having me here today. And it was really inspiring to hear Sandra's journey. So I'm just going to share my screen. Everyone see.
Yeah, just need to go to presenter mode, Tanya.
Yep. How's that? Is that all
yeah,
okay?
perfect. Yeah,
Lovely.
perfect.
So I'm Tanya. I'm one of the speech therapists at Great Ormond Street, and I'm going to be talking about early SLT rehab and interventions for ECMO patients through a pediatric case study that I'm going to present. I'd like to just start by kind of thinking a little bit about why early speech and language therapy input is required for our patients. There's lots of literature out there which has outlined the clinical risks for patients who have had prolonged periods of being intubated, long ECMO runs, particularly affecting their swallow and neurological function. We know that prolonged intubation can cause both sensory and motor swallow impairments due to potential laryngeal trauma, muscle weakness, risk of subglottic stenosis. And if these things are not picked up and supported early on, they can have significant consequences for our patients. In addition to this, we know that lots of the patients on ICU can present with critical illness neuropathy, delirium, and that impacts their communication and cognitive states. And so early SLT input can really support with identifying communication difficulties, not only in the acute phase of their journey, but ensuring that they have adequate support all the way through. So impairments can be picked up and that they're not left sort of entering education systems again, thinking about our pediatric patients without the relevant input and the appropriate input they need. Early SLT can also assess swallow function early on and ensure that safe oral intake can commence at the right time for these patients and to ensure they've got the right rehab packages in place to support them getting to oral intake. This will have kind of really beneficial outcomes for our patients and their families. So just moving on to my case study, it's a 14-year-old girl who was born prematurely at 24 weeks. She had chronic lung disease as a consequence of her prematurity, mild cerebral palsy with a hemiparesis, that's a baseline with developmental delay. Before coming into hospital, she was a verbal communicator, but used Makaton, which is a sign-supported system. So she would sign alongside talking, and she was fully orally feeding with no reported difficulties with her eating or drinking skills. She was transferred to Great Ormond Street for being in pulmonary hypertension crisis and requiring VA ECMO support. She was on ECMO for 10 days. She had 2 cardiac arrests and was intubated and ventilated for 30 days. Thinking back to my previous slide, sort of when we think about long-term prolonged intubation, that can be, the adverse risks to swallowing is anything from over 5 days of being intubated. So already this young girl is showing quite a lot of risk factors for why she may need salt input. The referral for speech and language therapy came in at day 4 while she was on ECMO. She was orally intubated, she was sedated but waking, and she was trying to communicate. She was using her hands to gesture, using her Makaton signs. But because of her global weakness and neuropathy, it wasn't clear what she was trying to communicate. So our priorities at this point was to assess her communication skills and to support parents and the staff in the unit to enable them to communicate effectively with her. So initially, we looked at her receptive language skills. It's really important that we have a good idea of what the patient can understand, so the language that we use with them, and how we can support them to get their message across when they are orally intubated. What was really clear with this young girl was that although she had some developmental delay, she had a really reliable yes/no response. So she was able to nod and shake her head really nicely. And for concrete questions, she could answer them appropriately. She struggled with like complex questions or instructions that had 2 or 3 key parts to them. And her mum was really keen for her to use sort of an elaborate kind of alphabet chart to spell out what she wanted to say. But looking at how fatigued and how deconditioned she was, and given that she wasn't able to use her hands so well, we felt that an alphabet chart was going to be too taxing for her, and the cognitive load was too high for her at that stage. So I implemented a really simple communication board, which had like 12 pictures on it in colour. And it was clear that she didn't want to point to them and didn't want to use it to point, but she was very receptive to me supporting her with this board by me labelling each picture, giving her time for her to say yes or no. So she was sort of using auditory and visually scanning the board. We were able to successfully support her functional needs on ICU. Was she in pain? Yes or no? Did she want the lights on? Did she need repositioning? So that was a really easy and effective tool that the staff and parents used with her. In addition to this, while she was on ECMO, parents were really strong advocates for this little girl to have psychology input to ensure that she understood why she was still in hospital for such a long time. And the more she was becoming awake, the more important this was for her family. So psychology were involved, and we were able to use some of these basic strategies to enable her to access psychology, sort of concrete yes/no questions, giving her time to respond, using visual support. In addition to this, making sure that the patient had things like her glasses, you know, little things like that are really important, like asking mum, did she have a hearing aid? Did she use glasses? And making sure those were present for her at that time was really important. As her time progressed with us, she came off ECMO and she was extubated, and our priorities shifted to thinking about her swallow function and what her voice and communication skills would be like now that she's extubated. She was still quite deconditioned, needing a lot of respiratory support, but she was interactive. She was beginning to respond appropriately, smiling, using frowns when she wasn't happy. Enteral feeds had commenced for her, so she was being fed by a nasojejunal tube, and it was really clear, and she was communicating quite clearly that she wanted to drink. So our assessment in terms of her swallow started here. We looked at her oral motor skills. She had limited an effort range of movement at that point. Her voice, she was mouthing, she was trying to speak, but there was no voice coming out. She was largely aphonic. She had high secretion load. She sounded wet and gurgly at rest and needed lots of suctioning. So, you know, a lot of red flags there already. On giving her sips of water, she would immediately cough, but her cough was weak and ineffective. So at this point, we had a strong suspicion that she had significant difficulties with her swallow and her vocal cord function. So we got a referral to ENT. We were thinking about working towards instrumental assessment with our ENT colleagues and ensuring that oral cares, which is a really important part of her cares when patients aren't eating or drinking, was put in place for her. So we did a FEES, which is a fibre endoscopic evaluation of swallow, jointly with our ENT colleagues. So the consultant passed a scope up her nose, a fibre endoscopic scope going. This is the scope going through her nasal cavity, and it's tracking down, and it just sits right up top here in her pharynx. That tube there is the nasal jejunal tube going through her upper esophageal sphincter. This is the epiglottis, and we've got here lots of thick secretions pooling in her piriform sinus. And that picture there, the bubbly picture, was her swallowing on command. So you can see here that even after she did swallow, there was still loads of secretions pooling in the piriform sinus. This was quite abnormal. And you can see them there tracking through over her arytenoids. And that's her vocal cords there. And you can see we're asking her to phonate, to talk. And one side's moving quite nicely. However, the other side, the right side's static. And you can see those secretions spilling in through her glottis, going down into her airway. What was also really useful with this tool is it gives us direct visualization of what's going on. And we could talk to her while she was on there saying, can you feel those there? And she'd say, no, she couldn't feel them. She wasn't always swallowing. So we had to prompt her to swallow. So this was a really informative tool that we had to support her rehab journey. Going to move on. So the results of that FEES assessment was that she presented with significant dysphagia and dysphonia. She had reduced airway protection and was aspirating secretions and water that we tried, and she had reduced efficiency. So it's not a question of could she swallow? Yes, the swallow trigger was there, but how safe was it and how efficient was it? And for this young girl, she had difficulties with all aspects of her swallow. And the ENT consultant diagnosed her with a right vocal cord palsy. There was no movement of that right side. And that's very much in keeping with her clinical picture that we were seeing. So her swallow rehab started here. We encouraged her to take single sips of sterile water, which she was more than happy to do. We ensured there was dietitian input to kind of optimize all her enteral feeds, because it was clear at this stage she wasn't going to manage oral feeding. And we got her to take some effortful, strong swallows, reactivate those muscles. She'd been intubated for 30 days. She hadn't been using them, so they were very weak. And then regular oral cares. And I think this last point is really important, the education about vocal cord palsy. Why couldn't she produce a voice? Why was she struggling with her swallow? And enabling her and her parents to watch the fees, understand what was going on, was really key part of getting her on board with the rehab that we were putting in place for her. As time went on, she had lots of MDT input, which we're probably going to hear lots more about today from our colleagues on the panel. But she made loads of progress. She became stronger. She was sitting out in chairs. She was starting to mobilize a little bit. Her respiratory wean was successful. She was now at this point in 3 to 4 liters of oxygen via face mask. She was established on nasogastric feeds, so that transition from nasojejunal to nasogastric was achieved. She was really motivated. Her secretions, as her gross motor skills improved and her overall strength, her secretions also improved. Her voice was coming back. It was still dysphonic, but it was there now. You could hear it. And what worked for this young girl was she wasn't that keen to use her voice still, probably because it sounded so different, but she used a whole range of things, and that's called a total communication approach. She would do a bit of nodding and shaking, use some visual support. She had like a little kind of whiteboard pad that she would write single words or draw things. And that worked really well in supporting her communication skills at this time. So we worked with the medical team and decided, let's move forward with her swallowing. And she really wanted to eat. So we got some pasta and yogurt, which is what she chose, and her mum's soup. From her oral phase, sort of her chewing skills, they were functional. It was slow and it was effortful, but she was sort of managing to break down that pasta well. And on clinical bedside assessment, there were no overt signs of aspiration when she ate or drank. However, she did desaturate when taking a large drink of water. And we weren't sure if this was because we'd removed her face mask in agreement with the medical team for the SALT assessments and for her feeding rehab, or was there some aspiration going on? So clinically, there was an improvement to her voice and to her swallow function, but we had this question of whether there was some aspiration risk still taking place. So we went forward and we completed a video fluoroscopy. At this point, she'd already transitioned off ICU. She was stable, came down to X-ray. This is a lateral view. It's a dynamic swallow assessment completed under X-ray. We gave her a drink of water. So here we've got her jaw. This space here is her oral cavity. Here is her pharynx. So when she had the fees in, the camera sort of sat up here. This is the valleculae. And down here are the piriform sinus. This bit here is her airway, and that there at rest is closed. It's the upper esophageal sphincter. I'm just going to quickly play. I'm running out of time. Here is her having a sip of water. So the black thing you can see in her mouth there is the drink, the water mixed with contrast that shows up. You can see it pulls into her valleculae a bit. There she's triggered a swallow, and it all tracks through her upper esophageal sphincter. And we did the same with food, and it was a very similar picture. So clinically, she had made loads of progress. She now had a nice functional swallow. She had effective airway protection and swallow efficiency. There was no residue left over when she was swallowing the water or the food we tried her on. So we pushed forward with giving her oral intake and letting her eat as much as she wanted to within the realms of her not being fatigued, and just thinking about timing of feeds with NG feeds, physio sessions, etc. She continued to have dietitian input to establish whether she still needed some top-ups to ensure she got all her calories in, as it's really important these patients receive all their nutrition so they can participate in all their rehab. And there was close monitoring of her chest health and clinical presentation. She did really well. So just to end, just some key points to think about. We know there's a high risk of dysphagia and swallow impairments and vocal cord impairments after prolonged periods of being intubated. It's really important to get early SLT input as part of your MDT. When you're thinking about supporting a patient's communication needs whilst they're on ECMO and awake, keep it really simple, functional. Make sure that your communication partners are as involved in that process as much as the patient, because actually often they're going to be the patient will be heavily reliant on other people supporting them with these tools. So simple, easy tools are the best, I would say. Family-centered care and education was also a really key part, helping her understand why she was having these difficulties, and her families really got them on board with getting her on track with taking part in doing effortful swallows and doing her swallow exercises. Oral cares are really key in patients who are not eating and drinking, to prevent adverse effects from bacteria buildup in the oral cavity, and just to plug, to get speech and language therapy input as referred as early as possible to be part of that MDT to support that patient's journey. Thank you.
Thank you, Tanya. A really amazing oversight from a paediatric perspective. So we're going to move straight on to our next speaker, who is Corinne Gaston. Corinne, I don't know if you want to put your camera on and share your slides. So Corinne is a critical care speech and language therapist from Royal Papworth. And she has a main interest in the development of technology to support speech and language therapy diagnoses and accessibility of people with speech impairment. How are you getting on, Corinne, sharing your screen? Just thinking about it.
There we go. Okay.
Oh, yeah, perfect. Thank you.
No worries. So my name's Corinne. I'm a speech and language therapist at Papworth, and I'm looking at the importance of international collaboration with speech and language therapy. So gold standard testing. So I was looking at ultrasound, the use of ultrasound. And prior to 2020, I was thinking about ultrasound as a form of assessment, primarily at that point for people living with ataxia telangiectasia, which is AT, and trying to kind of get support and funding for that. And the sort of questions that we that we kind of explored was why would we want to prioritize a form of assessment when we already have two gold standards of assessment, and as you've just seen, fees and video are really, really useful. But I guess it's kind of, what do we mean when we're talking about a gold standard test? And obviously, ideally, a gold standard test is a test that is 100% perfect. But we know that that often isn't the case. And we do know also, in terms of the present, it might not be that that's the gold standard in the future. And it may also be that the gold standard will vary across patient group and settings. And so the gold standard is a test that gives you the highest accuracy at that point in time. So with AT, video fluoroscopy was the best form of assessment, but increased risk from radiation of developing cancer means you need to put them on low dose. They are in a wheelchair, so they're not as close to the plate, so you're not going to get the clarity of imaging, and there's increased movement. So there's lots of things that might make it so that the images are less able to be assessed. And with ECMO, we will be looking at fees, but there's the issue around anticoagulants, secretions, painful nasal passages. So you may have issues in terms of visibility. They would need to be awake for the fees, generally speaking. So you've got the reduced epiglottic deflection, which sometimes it will sit up like a little shelf, and so you can't actually see the airways. So it is great, they are great, and we rely on them very heavily, but there are sort of challenges to using both those forms of assessment. So come COVID, these video fluoroscopy and fees were stopped. We had no idea when it was going to be reintroduced. In terms of direct clinical assessment, they presented with a very disordered oral phase, They had varying levels of cognition. Sensation was absent or poor. There was a fatigue effect. They were coughing throughout the assessment. So there was a high risk of the clinical assessment not necessarily being accurate, even if you were doing everything that you can. The other factor is that these patients have only just got over COVID, and you didn't want them developing an aspiration pneumonia and going back for two reasons. It's not good for the patient, but it was also that there was a lot of pressure on resources. But having a conservative route of keeping people nil by mouth, just be on this, because you can't assess and it's tricky, would also impact on stretched resources. And we also know the best form of dysphagia rehabilitation, if it's possible, is for people to safely eat and drink. There was the challenge of the idea of new tech versus familiar tech. So, for example, ultrasound versus a telephone or remote video. The idea that familiarity can seem safer, but in fact, it may not be less risk averse. So with ultrasound, it was in the use in the hospital, but not within speech and language therapy. So what we did was we put a protocol in place to minimize the risk of using ultrasound during the absence of ENT fees and video. So we didn't have those options. So we were going to basically just do an adjunct to the clinical assessment. There were two patients that we used the ultrasound with. They did need to be alert and able to fully consent because we needed to talk it through with them, because obviously we needed to explain the pros and cons of what we were doing. And we wanted to know their thoughts on the assessment. We wanted as much feedback as we could get in terms of what their view was. For the first patient on VV ECMO, they were trachy, they were COVID, they'd had a stroke. And there were lots of reasons why they might have a swallowing difficulty. And the tongue and the higher laryngeal movement felt normal, and I was definitely experiencing a bit of that at the time. It's very hard at bedside with these patients to know, I'd put them on oral intake, and it was really difficult. We did, and some of them would go, would start to have increased respiratory difficulties. So there was a lot of throat clearing. They'd become agitated. Then this triggered coughing, and there was no obvious fatigue. So we put them on sips of water, and then basically we did the swallow assessment, the clinical assessment with ultrasound. And what we could see was there was symmetrical movement. The tongue was within normal width. But what we noticed with yogurt, which kind of correlated with the coughing, was that after several teaspoons, there was reduced hyoid movement for that. So the recommendations went to liquids, level 1 liquids. We felt we were pretty confident that we could put the person on that, get them on something, get them rehabbing, and they were then transferred to their local hospital. The second patient had COVID. The voice was wet, but otherwise normal. But on oral intake, they were desaturating, skin color change. But again, the higher laryngeal movement felt normal. They had a very disordered oral phase. They would cough and splutter, and there was issues around the taste. So on the 26th, which was 2 days later, we did a clinical with enhanced ultrasound. They were very frightened, very anxious, needed a lot of support. And what we could see was, again, there was symmetrical airway movement. There was improved hyoid movement with the apple juice over the water. And what we suspected was there was a sensory element to this. And so we recommended level 1 to kind of thicken fluids and to kind of go with stronger flavored fluids. On the 27th of the 4th, we did the clinical with the ultrasound again. And what we found was there was ultrasound found normal movement. Palpitation did feel delayed, but we think that was probably to do with the slower oral phase. And we actually managed to get them onto level 1 to level 6. And then on the 29th, I didn't use the ultrasound. There was no signs of dysphagia, dysphonia, or dysarthria, and they were put on normal diet and fluids. And we acknowledged that this wasn't ideal, but actually when we started to introduce video fluoroscopy, what we did find was a high agreement between what we had found with the ultrasound enhanced clinical assessment and video fluoroscopy and fees. So what happened next? This led to the speech and language therapists from around the world meeting to discuss the safe and effective manner of introducing ultrasound after COVID. We looked at the evidence-based training needs, protocol, mentorship, and support of speech and language therapists across the world who were working in isolation in ultrasound. And in the 5 years since, there's been many research studies. We've got increased use, things like Botox, tongue biofeedback, hypertracking, and the 80 patients. I've just finished their pilot study, and we'll be moving to the next study. So these international groups still meets regularly to support speech and language therapists introducing ultrasound into their practice. And this ensures that we can keep the benefit, but also minimize the risk. And for ECMO patients, ultrasound could be useful adjuncts. They don't need to be fully awake, although movement is a factor. Anticoagulants aren't going to be a risk. I mean, you do press, but you shouldn't be pressing so hard. Equipment may be more widely available than these. And secretions and reduced epiglottic deflection wouldn't be a factor. So what lessons can we learn in ECMO? ECMO remains a specialist area, and speech and language therapists can be quite isolated, and it's an emerging field. And so speech and language therapists, benefit, particularly as a profession, supporting each other with a wider support network. So just like the webinar today, where we are this was part of a group to support each other, this is useful for speech and language therapists. And there's also a UK-wide group that's starting to collect data to look at protocols and training to try and get some standardization across the ECMO group. ECMO treatment can lead to complex situations, and what was really noticeable was how reliant I was on the patients and their feedback, and it was very much a partnership with introducing ultrasound combined with the clinical assessment, and they were really important in shaping that. And I would want to keep that going moving forward. The other thing is there a way to introduce new possible gold standards of care in a timely manner? So, could we have a way of harnessing the movement we were able to make in terms of introducing technology in a crisis period? Is there a way of doing that outside of crisis periods, and recognizing that gold standards of care are gold standards, but there are also, there's always room for improvement. And then, is there a difference in understanding risk and calculation across different groups and healthcare settings? That was very much something that I experienced, was an understanding of what risk is, and that familiar doesn't mean that it's less risky. And so there was a lot of discussions about risk, probabilities. So overall, I think ECMO is quite an emerging field, and through supporting each other, across different countries, actually, that is particularly beneficial for speech and language therapy. Thank you.
Thanks, Corinne. Really interesting presentation, and I'm a huge fan of ultrasound on the ICU, and I think this is another sort of one of the modalities that actually I think has got real potential, especially in ECMO patients. Just before we move on to the next speaker, we're getting lots of amazing questions. So what we are asking our panelists to do is to have a look in the chat and then answer sort of questions that are related to them as we go, just because we don't want to run out of time and not have answered any questions. So Corinne and Tanya will have a look in the chat and get answering. And then if there are time for questions at the end, maybe we'll ask a few more general ones. Thanks, Corinne. So I'd like to now introduce our next speaker. So we're moving a little bit away from speech and language therapy and thinking about sort of implementing mobilization on ECMO. And the first presenter is Kerry Pooley, who is a ECMO nurse specialist from Papworth. In addition to her ECMO and sort of nursing care of the patient, she is the unit nursing lead for resuscitation and respect. So Kerry, I'll invite you to share your slides and unmute yourself. Perfect. Amazing. I'll hand over to you.
Hello, good afternoon. Hi. Just want to say it was really, really wonderful to hear a previous patient talk, and it was really nice to get Sandra's perspective on her time with us at Royal Papworth. So as the introducer said, my name is Kerry Pooley. I work at Royal Papworth Hospital in the intensive care area as a sister, cardiac surgical and ECMO specialist. I've been asked to come and speak today regarding mobilising a patient on ECMO and very much plan to look at a team approach of this. I've approached the talk looking at the team and the practicalities of mobilising a patient on ECMO, knowing full well that my audience are experts in the area and very aware of the research regarding the benefits of mobilising patients on ECMO. So the contents of the session will be looking at a case study, looking at the team involved in the patient's rehabilitation journey, team approaches, safety considerations when mobilising ECMO, safety checklists that we use at Royal Papworth Hospital, and then some take-home messages. So the case study. So we've already heard from Sandra and her side of the journey. So I'd like to share our side of Sandra's case. So it was a 47-year-old female with diagnosis of ARDS secondary to dermatomyositis. The only significant past medical history was interstitial lung disease. The patient, so Sandra, was admitted to a local hospital with shortness of breath and fever. She was transferred to Royal Papworth Hospital under the severe acute respiratory failure team, transferring at that point without ECMO support, and we continued conventional management with proning. 13 days after the transfer to Royal Papworth Hospital, Sandra was put on ECMO support and tracheostomy was inserted. 139 days were spent for Sandra in critical care at Royal Papworth Hospital, and 116 of these days were on VV ECMO support. Very much a multidisciplinary approach, working closely with the interstitial lung defence team, and time on ECMO for Sandra was complicated by pneumothoraces, pleural effusions, and some GI bleeding. Trials to wean sedation, ECMO flow, and gas flow continued daily, and the ECMO, as I said, was removed day 116. 10 days later, Sandra was discharged to ward-based care at Royal Papworth Hospital to continue her rehabilitation. So critical care myopathy. Once Sandra was awake from sedation and when she was stable, Sandra was unable to move at all. When Sandra was stable and awake, mobilisation with ECMO commenced, and after many intensive rehabilitation sessions, Sandra was able to walk short distances, as Sandra very kindly shared her videos of that. So teams involved in patient rehabilitation. This slide shows the varied team members involved in the patient's journey. Team members work closely assessing and planning mobilisation. I've added here the 24-hour clock, as unfortunately these team members are not available 24 hours a day, 7 days a week. At Royal Papworth, the therapy teams and ECMO specialists work very closely together to plan rehabilitation goals. Because of this teamwork approach, when the therapy staff are not available, the ECMO specialist and ECMO-trained nurses can safely continue to mobilise the patient and follow plans set by our allied health professional teams. This also benefits patient experience, as patient may request to remain in the chair till late evening or get up and get out of bed early in the mornings. At Royal Papworth Hospital, due to training of our team, medical staff are not required to be present while the patient is mobilising. So the team approach. I'd like to focus on the team members required to be present when the patient is being mobilised on ECMO. The patient must remain at the centre of the team approach. Communication is very important before, during, and after mobilising a patient on ECMO. The team must communicate to one another, establish roles, responsibilities, and capabilities. The team should introduce themselves so everyone knows each other's names. Team members need to be aware of the goals of the session, and a backup plan needs to be discussed. This prepares the team regarding what to do if the patient becomes unstable. The patient also needs to know the plan of the session. The patient needs to know they'll be listened to and will have time to express concerns and have time to rest and recover during the mobilising session. The ECMO specialist is responsible for the safety of the patient and the overall management. They will be ensuring the safety of the cannula and the ECMO circuit. Often the ECMO specialist will take the lead regarding the plan of action and is often the member of the team checking to continue it safe by constantly assessing the stability of the patient. The ECMO specialist must remain focused and be prepared for any deterioration of the patient. The ECMO specialist is trained to make sure to accommodate stability to the patient. This could involve increasing ventilation, oxygenation, or flow on the ECMO. Whilst the ECMO specialist is able to make changes and ensure the mobilising the patient is safe, this supports the physiotherapy and therapy assistants to focus on the rehabilitation goals. This means they can feel reassured the patient is safe as they progress the patient through the rehab session. This may include sitting on the edge of the bed to assess core strength, supporting the patient to exercise limbs, sitting to standing, and when the patient's strong enough, the aim is to progress the patient to walking. The physiotherapist may implement equipment, so they may implement a tilt table, Sara Steady, hoists, or a walk-in frame. The ECMO-trained nurse will be allocated as the patient's bedside nurse. An ECMO-trained nurse is able to notice changes and deterioration of the patient and can escalate this to the specialist. They complete observations and can notice any differences in trends. During mobilisation, the ECMO-trained nurse must provide support for the patient. They can provide personal care, or they can be allocated to manage a cannula position along with the airway if the patient has a tracheostomy or is intubated. The healthcare support workers play an integral part of the team. They are experts with managing equipment, being slick with the furniture moves, and this ensures that mobilising can occur as smoothly as possible. They can also provide support and personal care to the patient. I've mentioned there and brought the family, so family may be brought in for rehab sessions. They can give the patient confidence, decrease anxiety, and be a great cheerleader. Mobilising will be exhausting for the patient, and when the patient is struggling, having a family member to cheer them on can support them positively. This might not always be appropriate, but certainly in Sandra's case, it worked very well. Sandra shared with her video as her husband was carrying things and helping along the way, which really did support her. Prior to mobilising a patient on ECMO, we need to assess and look at general things and make a good plan. So the first thing on this slide is the clinical stability of the patient. Is the patient awake? Are they calm? Are they agitated? Can they understand what we're asking them to do during the session? Is the patient cardiovascularly stable? Are the blood gases in set parameters? Is the patient already short of breath and struggling with their work of breathing? Have they already got an increased need for extra oxygen? Are the flows stable on the ECMO? The patient needs to consent. The patient needs to understand the plan to mobilise and consent to the rehabilitation session. Team availability. Often at Royal Papworth Hospital, the ECMO specialist and physiotherapist group together early morning and set times. They aim to mobilise the patients on ECMO. This means that we can ensure that the team's availability and the patients can also plan their day and know what the plan is and what's going to be ahead of them. It's really important to consider time. When commencing the session, all team members need to have time to stay for the duration and be able to focus on the session. The patient should never feel pressured for time, as they may need time to rest and recover during the session. Planning, the plan. So we need to plan together as a team and with the patient, explain the aims of the session and what we set to achieve. By preparing the environment, the most successful mobilisation sessions occur when everything is prepared. We need to check lines, medication, monitoring equipment, prepare the furniture and declutter the bed space. We also need to check availability and equipment is working. So before starting, we need to check the equipment and make sure everything's in safe working order. The backup plan. So as a team, we need to discuss if the plan needs to change. For example, if the patient is unable to stand or the hoist needs to, and have a plan that the hoist could be implemented. If a patient deteriorates, then we need to consider that we might need to stop. We need to ensure safety and reassess the patient. A patient may require pain relief. They might require an increase of oxygen, or they might require an increase in ECMO flow. They might also need some fluid to support the flow. If required, the session may need to be delayed if the patient becomes too unstable. So completing the safety checklist. So at Royal Papworth Hospital, we use a safety checklist prior to mobilisation. So we have a pre and post checklist for mobilisation. This checklist brings everything together. This should be completed as a team to ensure safety to the team and to the patient. So you can see it generally brings everything I just mentioned. So looking at the RAS score, the availability of the team, making sure flows are stable, anticoagulation is stable, ensuring the circuit is safe and ready to go, and also making sure that stitches, holisters, headband, all the things that are securing the cannulas are in place. The post-mobilisation checklist ensures everything is plugged back in and saved after mobilising. If the patient has left the unit, then the perfusionist must hand over and document the handover to the ECMO specialist. We use an extra checklist if a patient leaves the bed space or goes outside. We call this sunshine therapy when the patient goes outside. I appreciate this checklist is a very wordy document, If anybody is interested in reading our checklists or looking at them in more detail, then please contact the webinar organisers, and Royal Papworth's very happy to share any of the checklists that people may need to look at and review. This checklist ensures that emergency equipment goes with the patient if they're leaving the bed space or unit to have their sunshine therapy. It includes emergency drugs, suction equipment, a tracheostomy emergency box, the transfer bag, oxygen supply, and ensuring we've got sufficient monitoring so it's safe. The picture here shows sunshine therapy as its best, as a long-term ECMO patient gets a visit from her furry friend. The take-home messages from my presentation: preparation and planning. So prepare the environment and have all the equipment, emergency equipment and staff available. Backup planning. The patient may become unstable. Be prepared for cardiovascular instability, desaturation, loss or decrease in ECMO flow, and the patient may become distressed and short of breath. An ECMO specialist can support this with increasing flows and oxygenation, and by giving time to the patient. Stop and reassess. If the patient becomes too unstable, stop and delay the mobilisation. And remember, it takes time, dedication and commitment from the patient and the team to ensure the patient's mobilising session is successful. And always remember to be brave, but be safe. Thank you.
Thanks, Kerry, for that really comprehensive, I think, overview of all the considerations and everything it takes to achieve this. And we're now going to move on to our next speaker, who is Hannah Child. She is a specialist pediatric critical care physiotherapist from Birmingham Children's Hospital. Her special interests are ECMO, ventilation weaning, and early rehabilitation. We can see your slides perfectly, Hannah, if you want to get started.
Amazing. Thank you very much, Emma. So I'm going to kind of run through a similar sort of thing to Kerry, but just looking at it from a slightly smaller angle, as in a smaller person, because it's going to be pediatrics. So before I kind of tackle the ECMO side of things, I just want to kind of slightly illustrate the difference between where peds and adults are at from a rehab perspective. So in adult practice, there's really comprehensive randomized controlled trials that are quite long-standing that have shown really positive outcomes of doing rehab and shown that they can reduce length of stay, reduce time on a ventilator. So therefore, huge rehab teams are now formed and live on intensive cares units in adult practice. In pediatrics, we're still awaiting those big randomized controlled trials, one of which is currently running in the US, but we haven't actually got proven rehabilitation outcomes in pediatrics yet to kind of prove that rehabilitation does achieve the same things that adult practice has shown us. It hasn't stopped us continuing to do it, but we're kind of running on slightly limited evidence. What we do know from a pediatric perspective is that it's safe and it's feasible to do it. So we've got lots of studies now that have shown that in pediatrics, you can mobilize children as young as newborns, essentially, making sure that you've carried obviously appropriate safety measures. The other kind of thing to consider when we think about pediatrics and mobility is that our clientele are slightly different. So 70% of PICU children are generally aged less than 1 year old, which means from a rehabilitation perspective, you've got a slightly different take on rehabilitation and what rehab might mean to that patient. Lots of our patients aren't actually actively mobile yet, but it doesn't mean you can't carry out some form of rehabilitation for them and for their families around them. We also have unlimited visiting from our parents. So it means that they form a huge part of the MDT that we work with. And they have to be kind of very much part and parcel of that patient's journey. And they are kind of the advocate for their child as we carry on with their mobility practice. So because of this lack of evidence necessary to kind of prove the worth, what we do use is practice recommendations from an expert panel, which was a paper that came out a few years ago in 2017. And that's kind of given us a bit of an idea of how we should approach the same concept within adult practice. It's essentially using a very similar technique, but obviously we're doing it with essentially unknown outcomes as of yet. So when we kind of move into ECMO, we imagine it's even more limited or restricted situation. So patient selection is really key or a big consideration within mobilising our ECMO patients. Firstly, because a large proportion of our ECMO patients are babies, and of those babies are often cardiac patients, which means they're often centrally cannulated and may have chest open, which straight away limits what rehabilitation is available for them to do in terms of moving probably isn't really high on the list of what that child needs to do, or at least a high level of movement. So we look at the EuroELSO guidelines in terms of their thoughts on awake ECMO, and even they kind of point out the fact that it should be carefully selected in a group of older patients. So it's not that it can't happen, but maybe it's more appropriate to be seen in the older patient group. If we then look at an EuroELSO registry study, which was released in 2024, so a really up-to-date study, they again looked at 8 years plus of mobility, showing that 10% of those patients had generally achieved some sort of mobility. And I suppose ECMO is one of the only reasons, or one of the main areas that have actually started to get positive outcomes actually demonstrated with rehab, showing that actually there was a positive link related to mobility and then moving on to transplantation and survival within that cardiac rehabilitation group of patients. So patient selection, hugely key. When we move on to the actual rehab activity itself, we have to then adapt and think about how we address our patient population. So it needs to be age appropriate, but not only age appropriate, but also appropriate to their developmental status. So some of our children may be 5, but have a developmental age of a 2-year-old. We also need to think about the ability to comprehend that, and also the comprehension they then have on top of all the sedation and all the other things that are going on with that patient, and thinking about their compliance. And that might be their pre-illness compliance versus their current compliance levels. And all that needs to factor in. So often with adults, you can kind of explain this is why we're going to do that. It's more difficult explaining it to a 5-year-old who doesn't see the fun in that and goes, I don't want to do that. So it's trying to work a way around of how to get them on board and negotiate what we need to do. So from an ECMO point of view, from a safety aspect of things, we have got some evidence that it's safe and feasible in pediatric ECMO patients. So we've got case study reports, and then that's moved on to changing early rehab programs that were released in pediatrics, which initially, when they first kind of came about around about 2016, 2017, ECMO was often excluded as it wasn't actually deemed safe to do that with pediatric patients. As now it's very much changed. So if you look at Karen Chung's work, and she released a paper very recently, which is looking at trying to implement a rehabilitation bundle over in Canada. And they've got ECMO as being a moderate risk, which means you can do it, but you just have to apply caution, which obviously is a huge step in where we are with rehabilitating our pediatric ECMO patients. Another huge consideration in pediatrics is thinking about MDT and family involvement. So we've got a few extra people that build up our MDT because we need to consider things like place therapists, which are integral to trying to get these patients on board with doing what we want them to do. And thinking about other things like their schooling and how that can impact. These children often have a really busy day, especially those that spend a long time on our ITUs. And we need to try and make sure they have set amount of time to achieve everything they need to achieve in a day. So because we're in a situation where rehabilitation and ECMO is essentially few and far between, or the bigger patients that often are the patients that will do the big level of mobility, is not hugely often on our intensive care units, we kind of met together as a UK team, I suppose, of all the lead centres within the UK, and said, well, how can we provide some sort of guidance or put things in place to try and make sure that when those patients that do need to do that high level rehab, there's enough expertise and enough guidance out there for people to try and follow suit. So we got together and developed some guidelines essentially for doing just that. And this is a published article, which I'm going to kind of use as a foundation of walking through a case study is how you could use it. So I'm going to present my case study. So this is a 10-year-old boy with sickle cell disease. So he developed a sickle cell crisis and was found to have influenza A. So deteriorated very rapidly and ended up having to go on to VA ECMO. He then was converted to VV ECMO via neck cannulation due to Harlequin syndrome. And then after he'd kind of settled onto his VV ECMO, he was then found to be able to tolerate being awake and was really alert. And therefore we thought, well, actually, we probably need to do something about entertaining him while he's just sitting there on ECMO. So we talked about the benefits, and I know that I'm preaching to the converted because everybody understands and hopes we understand why we need to do this to our patients, but we need to think about maintaining and improving range of movement, maintaining or improving muscle strength, facilitating weaning off a ventilator, facilitating weaning off ECMO. And although we haven't necessarily got the outcomes, we strongly feel that we can get a faster return to function, we can aid psychological recovery, potentially reduce PRTU length of stay and reduce length of stay in hospital in general. So how do we go about doing this with a pediatric patient? So I'm going to pull directly out of our article, which basically gives you a step-by-step approach for how you can go about doing it. So what we've done is create acuity levels, which basically use the bodily systems as a way of grading your patient as to how sick they are or how unstable they could be. So it gives you an idea of what you then could do with that patient. So our patient, the 10-year-old boy we were talking about, he fitted into the fairly low risk category. So it meant that he was net cannulated, his ECMO flows were stable, he had a nice secure cannula, he didn't have significant inotropic support, his comfort score, so his sedation score was right where we wanted it to be, he wasn't needing extreme levels of respiratory support to maintain him, and he had no significant concerns with bleeding. So using that, we then pair that to our activity level score. And we know that people of a low level can either choose from activity level 4 or activity level 5. So it gives you a list of options, not an exhausted list, but basically a list of things that you could potentially do with that patient or would be safe to do with that patient based on the score that you've given them. So we looked at our 10-year-old boy and decided, well, what would be beneficial for him to do? What would he like to do? So we started to pick some activities off the list and see what we could do for him. So then we need to think about, we've decided how sick he is and how safe it would be to do things. We've then looked at what activities are possible for him to do. And now we need to think about, well, what's the next steps? How do we start approaching this? So MDT structured approach, very much like Kerry's outlined before. It's very much thinking about who needs to be involved and how we go about mitigating all the potential risks that we have there. So what we use with our document is a risk assessment that's already kind of pre-filled in, but basically works through a step-by-step approach, trying to mitigate any potential risks. So things like cannula management, are they secure? Who's watching them? Who's that role? How often we are monitoring those flows? Who's in charge of that while we're mobilizing? Things like airway management, have we checked the tape to secure before we're doing it? Who is holding that tube? Who's aware that we're doing this? Kind of trying to limit anything that could arise from those things, a bit like the step-by-step things that Kerry was talking about just now. We also have a ERM ECMO checklist, which follows a very similar sort of process that Kerry was talking about. So we're looking at pre-doing it, so making sure that the world knows it's happening and that the right people know it's happening and they're going to be there if they need to be there. That we know that we've screened the patient, we know it's safe and appropriate to do it. And we've got things like correct monitoring in place. We've done the section that we need to do before we start. Then we go on to actually immediately before we do it, making sure that everyone's aware of the plan and everyone has the right role and knows what they're doing. Then we go to during, making sure that we've got any pause or reassess. So if the patient develops any change, that we pause as a team, we reassess the situation, decide whether we should continue or whether we should stop, or whether we need to take a hold, and then whether we can restart again. And then afterwards, we then have an assessment of, is everything back to what it was before? Is everything where it was? Is everything still reaching? How is the patient looking? And if we were going to do it differently next time, what would that look like? So it's making sure we've got a really robust plan in place. So for our patient, so he ended up having a 10-day run on ECMO and had a 14-day stay on PICU. So we maintained his muscle strength and range while he was on PICU, either on or off ECMO. And this was how we went about doing that. So we did bed mobility on day 6. So this is shortly after we converted to VV ECMO, did some bed mobility. And when I say bed mobility, it's kind of, he was pretty much governing what he wanted to do. And we were trying to make it as functional as possible. So it's not just moving my leg. It was, well, okay, let's kick a football. And it wasn't just, I want to move my hand. It was very much like, I'll move my hand so I can press something on a screen and then I want to play that game. So it was making sure that we made it purposeful for him. Then the next day, we kind of got more confident as a team. We were thinking, well, actually, he tolerated that really well. We'd kind of already checked all the lines, all the cannulas reactioned while we were doing our bed mobility. So indirectly assessing for the next day. We then looked at going on to the in-bed bike, so onto the motor med, which he tolerated brilliantly and pedalled away. Then the next day, we got braver still and went for a sit on the edge of the bed, which he actively participated in, which is brilliant. He then managed to wean off ECMO on day 10, and then post coming off ECMO, he then stood still on the ventilator with tube in, but then stood and did brilliant standing and started to do some stepping 2 days after coming off ECMO. So in terms of his journey, his outcomes afterwards, so he one day after being extubated, he was literally up walking around the ward. And then discharged home 2 days after being discharged from PICU. So had a really short hospital stay and actually discharged very quickly off the ward. So obviously outcomes for patient were brilliant, but outcomes for the staff, the morale boost from a successful team effort for getting that patient up and moving, and the fact his outcome was so good was really good. So in terms of really good for boosting staff morale as well. So in terms of conclusions and take-home messages, so ERM is recommended in pediatric and neonatal ECMO patients, and it's feasible to do, just needs some careful planning. We need to think about careful patient selection, making sure that the activity selection is appropriate for that patient and the level of stability they have. Really making sure there's a full MDT engagement. So have we got occupational therapists present? Have we got a speech and language engaged? Is a psychiatrist going to talk to the patient about it pre or post? And our family on board with it? Thinking about that holistic approach to the patient while we're doing it. So have we optimized all of the A to H bundle, which is our kind of adapted A to F bundle in peds, which we've added 2 other things on the end, which is good nutrition and humanism. Making sure that sedation's accurate, that we're thinking about weaning as much as we can do, optimizing every aspect of that patient's care. And then most importantly, making sure the patient's involved in the process and family are kind of on board, are supporting, and we support family with the fact that this is something scary, but actually could potentially have huge benefits for the patient. And I'll let you put questions in the chat. Thank you.
Thanks, Hannah. Another really interesting presentation. I do realise we are running slightly over time, so apologies for that. We have 2 presentations left, and it looks like a lot of the questions are being answered in the chat. So if I can introduce our next speaker, is Kerry Engelbrecht. Kerry is a clinical specialist, neonatal and paediatric occupational therapist, and she supports infants born prematurely or with medical complications that might affect their development. So we'll hand over to you, Kerry.
Can you see that, Hannah? I mean, Emma, sorry.
If you just need to, it says double click to enter full screen mode. I'm not sure you've quite gone into, yep. And now just go, if you go to presenter mode.
Is that okay?
It's still just on the normal slides. If you go into slideshow, I can see your mouse. Just need to go into slideshow. Maybe on the top bar. Sometimes when you click it on the so the next, you were just nearly there. Slideshow.
Sorry, I am just trying to. It's open up on my screen. That's why I'm just.
We can only see. Well, we can just see it in the sort of normal. Have you got multiple screens open? I wonder if that's
just one actually. I
mean, we can see that, to be honest, we can see the slides. We can just obviously see what's coming next down the side, but we can't see anything else. So, I mean, you could continue with it like that if you wanted.
Okay. Let me just try one more thing and then we can get going.
Maybe stop sharing and then.
Let me try that.
If you share first and then go to the presentation, then go to slideshow. So share the presentation first. This looks
How's
more
that?
promising. I saw you click on from beginning, but it hasn't changed. Some unknown reason. I think that's fine. We can see the slides, Kerry. Yeah.
Okay, thanks, Emma, and thank you for inviting me to speak today. As Emma said, my name is Kerry, and I am going to be speaking more specifically of the role of pediatric occupational therapy in ECMO, and in particular with one case study with a baby that was with us at the Royal Brompton Hospital for a couple of months, and I'll be speaking about the acute phase and how we were involved. So just an overview, just an introduction of the role of OT, thinking about the challenges in the acute phase, and then I will be showing a case study, in particular looking at developmentally supportive care for our infants, what assessment and intervention.
Sorry,
like.
Kerry,
Yes?
your slides are not changing because we can't see your slideshow. That's it. Yeah, you need to go down.
Sorry, is that better?
Yeah,
Okay.
yeah. It still isn't slideshow, but you'll just have to change down the slides as you go, I think. Sorry.
Okay. No, that's fine, as long as you can see. So just with regards to the pediatric occupational therapy role, so pediatric OTs play a specialized and essential role in the care of infants and children on ECMO, and are often at high risk of developmental delay and neuromotor impairments. And OT involvement is critical for both during and after ECMO support. And you can just see from this diagram here, in complex care situations like ECMO, there is no single discipline that can meet all the needs of the child and the family, and the care must be truly interdisciplinary with shared goals, ongoing communication, and mutual respect. So just a case study that I will be speaking about was a baby named Baby T, who was born via elective C-section, born with SATs of 40s, responded well to PEEP, and was put on high flow nasal cannula. And Baby T was transferred from the Royal Brompton to the Royal Brompton Hospital from Chelsea Westminster Neonatal Intensive Care Unit with TGA and 2 small VSDs. She had a balloon septostomy on the day of birth and arterial switch operation at 31 days old. And she had a cardiac arrest post-op and thereafter required 35 minutes of ECPR. And she was on VA ECMO for a total of 7 days. So just thinking about how we were involved, obviously initially, and what we were looking out for was a lot around neuromonitoring. So she had, throughout the time on ECMO, Baby T was closely monitored for signs of neurological compromise, a known risk in critically ill infants, particularly those requiring ECMO. She had routine neurological observations, so regular bedside neurochecks that were conducted by the ICU team to monitor for changes in tone or pupil response, movement asymmetry, seizures, etc. She had regular cranial ultrasounds that were performed, and all of these were reported normal. And then she had a MRI brain post-ECMO, which showed tiny old leukemia infarcts, but given her history of the brain, it was remarkably normal in appearance. So just thinking around a huge role of what OT does in the acute phases is really thinking about family engagement and empowerment. And in the acute phase, OT involvement is really delicate but critical. And we're looking at balancing the child's medical needs with the need to protect and support early neurodevelopment as well. And we know that our parents often feel helpless during ECMO. They're often in crisis mode. And it's really the timing of when we go in to introduce ourselves and to get involved. But in this situation, Baby T's family were really receptive, and we supported them a lot through coaching on comforting touch, thinking about hand-holding, containment in those early stages that didn't interfere with medical equipment. And I'll go a bit more detail now into what that looks like, but just thinking about encouraging that early bonding through talking, through singing, through scented cloths, gentle touch to the non-cannulated limbs. And it may seem quite small, but often these small but powerful interventions can really help just with connection, reducing stress, and thinking about that early development, even in critical care. And just maybe important to note that we quite fortunate at the Royal Brompton Hospital. We have a dedicated neurodevelopmental therapy team who's made up of an occupational therapist and a physiotherapist, and we work really closely together and collaboratively with supporting these infants in the acute stages. So a broad evidence-based family-centered approach that I'll be going into more detail is thinking about developmentally supportive care. And really, a lot of the time we think about this in the neonatal intensive care unit, but actually how beneficial and useful is using this approach in the pediatric critical care environment as well, especially thinking about our high-risk infants. And really what this is looking at is protecting and promoting the neurodevelopment, sensory integration, and emotional well-being of the infant, as well as the physical health. And in the ECMO context, especially where patients are extremely vulnerable and often medically unstable, developmentally supportive care can even be that much more essential, not just for survival, but thinking about optimizing long-term outcomes as well. We know that a lot of our infants are on sedation, paralysis, they have prolonged immobilization, they can have altered sensory experiences, disrupted attachment and bonding, increased risk of neurological injury, and often delayed or missed early developmental milestones. And therefore, developmentally supportive care on ECMO really does focus on reducing the negative impact on the ICU environment and invasive treatments, whilst really thinking about gently preserving and nurturing normal developmental processes. So, as a lot of you know, a lot of occupational therapy's role is thinking about adapting the environment. And particularly here, we know how stressful the ECMO environment can be. And with occupational therapists, we think a lot about sensory regulation as well as environmental control and adaptation. And infants on ECMO are at risk of sensory overload or deprivation. And OTs really try and support here with providing a calm, low stimulation environment as best as we can in a very medicalized space. So a huge goal really here is thinking about reducing sensory overload and supporting autonomic stability in the infants on ECMO. And it can really be such simple strategies, looking at minimizing the overload by dimming the lighting, reducing noise and unnecessary handling, thinking about if babies are in incubators, thinking about covers, providing gentle, age-appropriate, positive touch. As we know, our babies are so, they have so much negative touch experiences going on. Many procedures are thinking about how we're supporting positive touch experiences, whether that looks like hand containment, bringing in parents to support with voice, talking, familiar sense. And it really does matter in these situations to decrease our stress responses, but also thinking about promoting that autonomic regulation and supporting that early sensory development, which we know our infants are deprived of early on. So, sorry, just next slide. Looking at the sensory environment, this is a really nice kind of table that illustrates what we'll be doing in, with regards to the different senses. And really, again, occupational therapists' role in the critical care environment, especially with our babies on ECMO, is thinking about creating a therapeutic and healing environment to protect the developing nervous system. And there are a lot of evidence-based practices and just thinking, you know, a lot of the time about how we're reducing the need for sedation as well, thinking about our supports of delirium prevention, which I know previous speakers have gone through in detail, and just thinking about enhancing infant engagement. And here are just a couple of examples on the slide for you. Okay, so as I mentioned with baby T, she was with us on via ECMO for 7 days, and just thinking about what it looks like when baby T was stabilized and progressed beyond ECMO. Therapy input obviously shifted towards early intervention, play, relationship building, and really a strong emphasis on family involvement. I know Hannah mentioned that previously, but this is really something that we kind of bring into our practice as much as possible, building that rapport with family and getting them involved. And something that we do use is the early intervention or the EI SMART framework, which is essentially a co-produced transdisciplinary and evidence-based approach, which supports holistic family-centered care through collaborative clinical reasoning and integrated service delivery. So what therapy looked like later on, when appropriate and when it was less medicalized, was really thinking about that early rehab and what early rehab looks like for babies and infants. So thinking about encouraging that skin to skin and cuddles when baby T was stable. Occupational therapists support a lot with supporting parents understanding their baby's behavior and reading stress signs and cues. And the reason why we kind of hone into this a lot is to support with responsive caregiving, to support parents with that. We know that they need to adapt to a parenting role inside the hospital, and that can be really tricky. So really supporting them with confidence building around those caregiving skills is a huge role of what we do. And then thinking about establishing routines with their baby as well, often not what they expect in the hospital. So thinking about how we can really support them at that level. And this phase of input not only supported baby T's development, but also helped her parents feel empowered, connected, and really central to her care, laying a really strong foundation for long-term outcomes. So just thinking a little about what assessment and outcome measures we used, a structured evidence-based approach is followed to assess and monitor neurodevelopmental outcomes in our infants, and particularly those who are high risk due to medical or neonatal conditions. So in this case, with baby T being on ECMO, it was really important that we followed that robust structure. So kind of things that we did, we're looking at the Hammersmith Infant Neurological Examination. This is often used, a tool for a baby between 2 and 24 months. Thinking about Prechtel general movement assessment. So this is a highly evidence-based tool with strong predictive validity for cerebral palsy, and in conjunction, this is used with the Hammersmith Infant Examination as well. Something else that I did jointly with parents was the Newborn Behavioral Observation tool. And this is a system, while it's not a diagnostic, it's an evidence-based tool that supports early identification of regulatory or behavioral difficulties and really looks at promoting parent-infant interaction. So really thinking about that strength-based tool and supporting parents with that. And then probably worth mentioning that we have a follow-up program at the Royal Brompton and Evelina, and our physiotherapist is present at the follow-up ECMO clinics, and here a Bailey is performed when the baby reaches 2 years old. So just thinking about ongoing therapy input for baby T, it obviously didn't end here. And although a lot of her assessments she scored well in, she still required ongoing intensive therapy support whilst being an inpatient with us. So she did have an extensive neurodevelopmental input kind of during her admission. We put together an individualized program which incorporated all different disciplines, occupational therapy, physiotherapy, speech and language therapy, and this was updated regularly, thinking about joint goals together. She had a multidisciplinary team meeting at discharge, and she was 7 months old at this stage, and she presented with some motor and feeding delays, which we were then picked up, and she was referred onto the community for further support. And she has follow-up with our neurologist and the multidisciplinary team, which is wonderful. And as you can see from the pictures, she's doing incredibly well, and I think a lot to note about all the early intervention that she received and how amazing her parents were with the amount that they did with her in hospital. And just a final thought or a quote from parents, which really just showed the impact of how the therapist supported them. She said, "Dear developmental therapy team, we wanted to say a huge thank you for everything you have done for baby T. At 7 months old, she may not be where a healthy peer would be, but considering how sick she has been, we think her recovery is pretty amazing. She is so cheeky and curious, and she's kicking and punching with all of her might. Your guidance and advice has been an important part of our time here, and we've really enjoyed your company too." So thank you very much for listening, and we have some useful links and resources if that would help as well.
Thanks, Kerry. Just leave that on for like 1 second
Perfect.
or so while people maybe take a screenshot.
That's fine.
Thanks.
Okay, sorry about the presentation. I hope it worked okay in the end.
Yeah, no, we saw all your slides. Thank you. So I'll ask you now to stop sharing, and I'd like to introduce our final speaker. So last but not least, I'd like to introduce James Bruce, who is a critical care occupational therapist from Bristol. He's interested in upper limb dysfunction, post-critical illness, and long-term functional outcomes. And he is going to give us the adult OT perspective. So thank you for waiting, James, and perfect slides there. Over to you.
Thank you very much for the introduction. Hope you can hear me okay, and welcome everybody. Fascinating afternoon. So good afternoon. I'd like to say thank you to EuroELSO for the kind invite today. I'm James Bruce. I'm an occupational therapist working at the Bristol Royal Infirmary, ICU in the UK. In my spare time, I also sit on the Intensive Care Society Council, and I also chair the AHP Professional Advisory Group for the ICS. And I do spend a little bit of time co-chairing our AHP Southwest of England Critical Care Network as well. So it keeps me busy and out of trouble. Today, I'm going to be talking about the emerging role of occupational therapy treating adults requiring ECMO. Let's just see if this works. Okay, so let's look at the content, so there's no surprises for you. So we're going to start with a definition of what occupational therapy is, because I imagine lots of the centres on the call don't have access to an occupational therapist in your adult ICUs. We'll also explore the evidence of OT in ICU, and we'll also explore the evidence base for OT in ICU working with ECMO. I'll give you a little insight into what we're doing here in Bristol, and I'll try and convince you by the end that you all need an OT in your adult ICUs working with your ECMO team. Okay, so very brief about what occupational therapy is. So the Royal College of Occupational Therapists define the role as the relationship between activities service users do every day alongside the challenges they face within their environment. The therapeutic structure is often centered around goals and adjustments. Our approaches are generally practical, realistic, and personal, and we tend to use purposeful activity as our tool to engage the service user in therapy or rehabilitation. So kind of where are we as a workforce? So back in 2020 and 2022, we found that there's just not enough OTs ring-fenced to work in adult ICUs with the appropriate ICU exposure and opportunities to flourish. So as a profession, we're starting on the back foot, working with little evidence to back us, unfortunately. But our numbers are growing and our workforce is growing, which is really exciting. Okay, so let's look at the evidence kind of supporting OT in ICU. So in the mid to late noughties, we explored OT feasibility in ICU, and the results were really positive, showing an improvement in patient functional outcomes, and it was okay, and it was safe for patients to kind of receive occupational therapy on mechanical ventilation, and there was little adverse events, even with the most complicated patients. Moving into the 2010s, we found that the role was integral to kind of supporting an MDT in ICU. The role was justified with positive effects with delirium and communication interventions, and the key areas of role acknowledgement were the use of powerful and purposeful activity to enhance physical, cognitive, emotional, and ADL recovery. So, where are we with OT evidence with ECMO? Unfortunately, it's like searching the desert for water at the moment. There's very little out there. But there are a little kind of oasis of potential developing in that middle of that dry desert. So kind of in 2022, there was a paper from Chicago. There was a team exploring a single center study looking at 67 ARDS patients receiving VV ECMO. They explored intervention timing for physio and occupational therapy, and the interventions included mobilisation, engagement in activities of daily living, collaborative goal setting, and structured interventions. They looked at OT and physio input starting within 7 days of ECMO implementation versus OT and physio input post 7 days of ECMO implementation. Their outcome measures were the use of distance mobilized on discharge and the outcome of the AMPAC. The AMPAC is the activity measure of post-acute care, which is a tool looking at scores from 6 to 24. The higher the number, the more independent you are. What they found was obviously starting early was more beneficial, which was fantastic. The kind of early group walked 92.1 feet more than the kind of later group. And the kind of AMPAC score was much higher. It was kind of 4.1 points higher, which indicated that people were less dependent, which is fantastic. If we look at a 2024 scoping review, again conducted in the US, unfortunately not much to scope. There was 33 studies at this stage, but they did a really nice kind of job looking at kind of what the evidence showed. And in this pie chart, you can kind of see that representation. The large chunk represents the scoping domains that kind of are in the OT ECMO literature, and you can see the majority is physical, functional, and sensory. But the small chunk of the pie represents the areas that are not referenced in the OT ECMO literature. And there's some big kind of hitters here, some big players, including kind of mental health, spirituality, delirium management, and sleep. So in my humble conclusion, there's lots for OTs to research in the next 5 years. Please help us out. So let's move our attention to Bristol. So what are we doing in Bristol? We're really lucky and we're really fortunate. We've worked really hard to kind of have a fully integrated OT, physio and speech and language service within our ICU. And collaboration really in Bristol is our superpower. We try to kind of best think about the person and what their drivers and their barriers are, and try to understand these basic things can save a lot of time with engagement. So communication with the next of kin and significant others are really important. We try to tailor our approach to patients' interests and what's purposeful to them. We try to think about 3 domains and trying to keep it simple. So looking at the physical domain, how can we mobilize early? How can we educate about kind of fatigue management? And how do we build on our activity tolerance? And how do we give our nurses and our medical team a 24-hour structure to kind of follow when we're not there? If we look at the cognitive domain, we try to normalize the impact of their experience early. We try to promote non-pharmacological treatment for delirium. We haven't kind of got there yet, but we're still working on that one. Collaborative goal setting is really important when you can do it. Promoting clean, non-medical sleep hygiene. Again, we're not fab at that, but we are trying. Looking at mood and family education, and these are all key kind of keystones that we're trying to push to support early psychological recovery. If we look at the sensory domain, this includes kind of pain management, positioning of limbs, providing desensitization programs early when we can, and exploring sensory integration. So this is the organizing of sensory information received from one's body or environment. And also we're kind of trying to kind of learn from our kind of pediatric teams and try to explore sensory profiles. So which things in normal life agitate us, excite us, and make us withdrawn? If we can understand our patients better, we can get better results. Upper limbs are essential to explore our surroundings, especially kind of a clinical environment like ICU. So structured rehabilitation to progress our use of our arms is really recommended. This may be in the early stages, looking at splinting or positioning when somebody's on ECMO, and it can kind of build up to kind of self-care tasks during sedation breaks. We can try and encourage and engage kind of patients to kind of use their arms and their hands within games, practicing writing, and even building Lego. That's my favorite. From my experience, obviously adding an element of fun or competition to a session really engages engagement. In ICU, we don't really normally complete lengthy assessments because the patients don't have the tolerance or concentration to engage properly, especially looking at cognitive and psychological assessments. Regarding the cognitive recovery, we tend to do a series of MOCA 8.1s or MOCA blinds just to gain a benchmark, just to see where the patient's at. And then we complete low-level kind of cognitive worksheets with the individual just to kind of push what they've got. Regarding psychological recovery, we normally complete the IPAT, which is the Intensive Care Psychological Assessment tool. This is nice and easy. It can be delivered without a script, and it gives you a score and a line in the sand for you to consider kind of ongoing psychological assessment. But the best thing kind of with my experience of using this tool, it's not kind of the score and it's not the questions, it's just giving the patient an opportunity to actually talk about the hallucinations early so we can normalize the process so they're not holding on to it too long. There's lots of mobility scores out there that are validated in ICU. We tend to use the Manchester Mobility Score. This is the Intensive Care Mobility Score. And again, in essence, what you do at discharge, you get an allocated score for that individual's functionality. And this is really nice for benchmarking and looking at cohort studies. And also to refer onto a handover to the ward team. As you all know, and what we've heard from this afternoon's webinar is, you know, these patients are super complicated. They're the sickest patients in your region normally, and they can't rely on just one profession to aid their recovery. It really is a team approach. And to do it properly, you need your MDT friends. Each profession has a different lens they look through. And again, in Bristol, this collaborative approach is our superpower. And if you can get it right, the patients get the best comprehensive assessment to optimize their recovery. So here we are, we're looking at our kind of rehab for our ECMO patient in Bristol receiving their rehab. Her goal was to comb her hair. At this point, as you can see, she's rather weak, so she needs a bit of help. So in the picture, we've got a physio aiding her trunk and core. We've got a physio on the airway. And we've also got a specialist nurse monitoring the ECMO tubing. And we've got an OT in the front facilitating the upper limb to engage in the activity to work towards her goal. In Bristol, we're a new service. We only started ECMO in late 2022. So we've learned a lot on our feet and we try to be proactive with our process. So our occupational therapy team track all of our ECMO patients using the FIM-FAM-E. So what's that, I hear you say? So the FIM-FAM-E is the functional independence measure, functional assessments measure, and the E is extended. So what you can do here, you can kind of put this outcome measure, which is over 30 ADLs, onto a radar diagram. The closer to the middle is that you're more dependent on care or support, or you're not doing a task. So that equates to a 1 score. If you're a 7, you're fully independent. So the further out of the circle, the more independent you are. But the really good thing with this is that you can kind of plot somebody's recovery. So this person was totally independent before on the blue. Red, you get more of a polar effect, so you get a circular support coming into the middle. So their physical elements were quite needy on care, but this individual psychologically and communication-wise was fully functioning, which was really interesting, kind of understanding their kind of ongoing recovery. We kind of provide follow-up at 3 months, and that's an MDT collaboration. And at 3 months, we scored him again. And again, you can see that the physical domains and the ADL domains are the ones that he's struggling with. I had the opportunity to follow this guy up 20 months past his discharge. And again, it was surprising to see kind of where he was in his trajectory of his recovery. And as you can see, the difference between the purple and the blue, he's still struggling with his mobility and his stairs and kind of accessing his community. But again, understanding his limitations and his emotional status, these were big factors with him still, nearly 2 years down the line. If we look at his quality of life indicators, we use the EQ5D5L. And at 3 months, we scored him. And then again, I scored him again at 20 months. And not much has changed, which is a bit of a concern. But I think this is the reality. It's telling you that some of these patients have chronic illness post their ICU impact. If we look at the issues raised at 3 months, these are all things that we see in our follow-up clinic. But again, at 20 months, there wasn't much change, which was a bit of a concern. The really good thing with the FIM-FAM and the E is that you can kind of look at cohorts. So you can kind of look at the trajectory of your cohort of all your patients through their stages. And it tells a really nice narrative. So the blue is kind of their pre-admission, so kind of normally quite young cohort, quite functionally fit with a low frailty score. Obviously quite a huge range of discharge, but obviously quite dependent at that stage. And then at follow-up at 3 months, getting there, but again, a huge range that you're not back to your baseline. If you pull out the extended ADLs, this is really important, and understanding kind of that transition from hospital to home. These are the things that people really struggle with. So kind of meal preparation, laundry, doing their housework, shopping, home finances, and returning to work or education. Obviously, the OT ECMO evidence base is poor. So we're quite concerned as a small team in the UK and Ireland. So we've got our heads together, all of the lead OTs within the 7 or 8, kind of including Ireland, ECMO centres. We have joined a network and we've set up some aims and objectives that we really want to work on. We're getting our house in order. We're going to elect a president for that, or a chair, and we're also going to look at a research role as well, just to push the story and the narrative that we need more kind of OT ECMO evidence base. So I'm going to end by why your team need an OT. So we're generally very nice. We're very kind of friendly, and we're quite holistic in our approach as well. And we're autonomous practitioners. So we can help you kind of with your cognitive and sensory rehab. We can facilitate early mobilization and physical rehab. We like to frame our interventions in ADL tasks and build independence as soon as possible. We can support the psychosocial and low-level anxiety management of your patients, including relaxation. And the evidence suggests that we can support and reduce length of stay and reduced readmissions. I'd like to end our talk by just saying that the patient recovers better if we work together. I'll thank you for your time because we're overrunning. Thank you.
Thank you, James, and all the previous speakers. Your last slide was one of the sentences I had in mind to share with the audience who's still with us. Bringing joy and enthusiasm to work really aids to the recovery of our patients. I think that's one of the lessons I really learned today, working together in providing the best possible opportunities for recovery. Because we're over time, most of the questions were answered in the Q&A. Some email addresses were exchanged, so hopefully if you still need something, you can ask that to one of the presenters or send an email to the EuroELSO, and we will try and help you. We would like to conclude and end this webinar, and hopefully see you again with one of the other webinars organized by EuroELSO. Thank you very much.